Karen. So my name is Jill. I'm a workers' comp case manager. I work for Teal Networks. I'm a director of nursing, among many hats I wear. But Teal is a new cost containment tool to save workers' comp carriers time and money on imaging, therapy, and home care services. We assist with scheduling timely care with cost-efficient providers. By contacting directly with the providers, Teal becomes the payer, and we guarantee timely payment to any in-network provider for the services they're offering our injured workers. This ensures timely scheduling by removing the need to pre-cert health insurance for backup, which can delay care sometimes as much as 7 to 10 days. For imaging and therapy services, we'll work with the injured employees to secure appointments with in-network providers who've agreed to expedited scheduling, quality care, and reasonable costs. The Teal case manager will ensure timely scheduling of appointments. We confirm the injured worker attended as scheduled. We'll assist with reschedules if not. And then finally, we obtain the medical reports for the adjuster and/or assigned case manager on the file. When someone's moved from a higher cost out-of-network provider to a Teal provider, the cost savings from the switch can be pretty significant per occurrence. So this is a brand new product we've just recently launched. We're still in the real new soft launch phase. New Hampshire only for now. CTs and MRIs also for now. Therapy services will launch in early 2025, and then home care services sometime around mid-2025. Since launch, the average savings percentage across all referrals has been about 28%, and the average savings per MRI has been about $1,400. The average time from adjuster approval to the actual appointment date has been just 3 days. So that's a pretty quick turnaround time once we get the approval. The website has a very simple referral form that can be completed by an adjuster, case manager, or ordering provider. We've just asked for bare minimum information, so no one's spending a lot of time trying to refer someone over. And then all referrals have a single point of contact. And they're managed by workers' comp case managers, not general admin staff. So everybody involved in the referral is very familiar with the workers' comp process and very savvy related to workers' comp. So that's pretty much it. Again, it's a very new product, but so far it's been exciting and going well. And we've been working with New Hampshire Orthopedics quite a bit. So we'd love the opportunity to work with any of you on any New Hampshire imaging claims to start. And then as we expand and roll things out further, other services as well. The QR code on the screen will bring you to our website. And then there's a workers' comp page in addition to a health page and an international page for another service. So, but the referral form is under the comp page. So thank you.
I'm going to, Dr. Margolis and I are sharing a computer, so I'm going to let her tell a little bit about herself, but I'm going to welcome her. She's going to speak today on concussions in the workplace. Hi, everyone. Thank you for having me and inviting me to speak about this. I am Deb Margolis. I am a family medicine board certified physician. I have been doing primary care for 12 years, and then I switched into urgent care medicine about 12 years ago. With that, I've done quite a bit of occupational health, first injury evaluations of many patients and workers. So I've been working a lot with concussions over the years and have started doing some independent medical examinations as well over the last few years. And I'm happy to talk to you about concussion in the workplace and strategies for treatment. Okay. Sorry, we're having a little mouse issue right now. All right, hopefully you guys should all be able to see that now. If not, let me know.
Deb,
Yeah.
go slideshow from the beginning, then you'll get full slides.
That's what we did. It's showing on one screen.
Far left top top
Yeah.
of the,
From the beginning.
you want to click on that.
Yeah, you should be able to see the full screen. No?
No, we're still seeing it with the sidebar, but why don't we move on? So
All right.
not
Let
to,
me, yeah, I don't want to delay your time here. All right, so.
and it looks like your camera is facing the ceiling. They don't see you at all.
Ceiling. Karen's my technical advisor here.
Okay, there you go.
All right, sorry. Okay, so let's just start back from the beginning here. Of course, now I want to go back.
You're at the first screen. You're good.
All right, so concussion in the workplace. Here we go. Let's have some fun. So this is an interesting topic because there's a lot, a lot of head injuries happen in the workplace, and it's a really difficult thing to assess. It's not like an obvious X-ray image. Oh yeah, there's a break or there's no break. It's it's going to be challenging, so to speak, to identify these patients. Again, I talked a little bit about my experience as a board-certified family medicine physician working in urgent care for many years. I've done some certifications. I'm from the American Academy of Brain Injury Specialists, CDC Heads Up, as well as Impact Certified. The objectives here to talk about concussion, give a definition of concussion. You'll often see MTBI next to the word concussion, which will mean mild traumatic brain injury. And those two words are pretty interchangeable, concussion and MTBI. We're going to talk about various mechanisms of injury for concussion, consider the impact of concussion in the workplace, review the examination and testing for concussion, learn the signs and symptoms of concussion, review concussion profile types, discuss current treatment plans, review prognosis of concussion, and understand the development of post-concussive syndrome as well as persistent post-concussion syndrome.
Deb, the slides aren't moving.
Okay, slides aren't moving.
So I think if you just use your button
See
to
them now?
go, no. Use your mouse to move down from slide to slide in the left-hand corner.
Yeah, that's what I'm doing. All right, hang on. I'm going to try one more thing. I apologize, everyone. We're just going to do it. So one more time, we're going to try to share this and see if we can get it to work. All right, is this working?
No, there's nothing coming up.
No, it says they're not moving yet.
All right. All right, so I'm going to keep talking while Karen tries to figure this out a little bit for me.
I do have the backup slide deck. I know you have some changes. I can pull those up immediately.
There's one message in the chat that says go up to the middle. Can you see that button?
Display
Minimize
setting.
screen.
Oh. Did that work?
No.
I think it's this one. That's the problem.
Why don't I pull my backup up and
Okay.
use it? I mean, because it's already 20 past.
Yeah.
Yes.
So, and I did shorten it a bit, so hopefully we'll have a little bit more
Okay,
time
well, you can tell me
as well.
to
Yes.
move on.
Yep, you got it. So as we're trying to get that up, the next slide I want to talk about, which you'll see hopefully in a few minutes, is how do we define concussion? There's a lot of different academies out there, a lot of different people who, you know, whether it be the emergency medicine physicians, the neurologists, the physiatrists, you know, basically they all each have their own individual version of the definition of concussion, but it's basically a trauma-induced alteration in mental status that may or may not involve loss of consciousness. Next slide. There's different types of injuries, whether it's a direct head injury or something falls on you or you hit your head. There's also that whiplash type injury called coup contra coup injury, where just that motion of the brain shifting back and forth in the skull is enough to cause some shearing on the microcellular level and cause concussion symptoms. Okay, next. Again, this slide talks to a little bit about there's so many different definitions and academies of people who kind of are all trying to figure out what the exact definition of traumatic brain injury is for concussion. What's important about this slide is it's a traumatically induced physiological disruption. It's not something that you can see. It happens on a cellular level. Any period loss of consciousness, loss of memory before or after the events, and change in mental status, whether there's confusion or they're dazed. And the important thing about the mild concussion syndromes are that the severity of deficits does not lead to initial Glasgow Coma Scale or GCS of less than 13. Okay, next. So this is just a quick reminder of what the Glasgow Coma Scale looks at and how they grade it. Basically, 13 and above is 15 is perfectly normal, and we look to this as you'll see this referenced after head injuries what their Glasgow Coma Scale was. It looks on whether they're opening their eyes, their verbal response, and motor responses. Okay, next. So head injuries in the workplace occur in all age groups. In the United States, 1.5 million traumatic brain injuries occur annually. 75% are classified as mild and cost at least 17 billion each year. And you guys probably see more of this than I do. According to the Bureau of Labor Statistics, head injuries in 2020, 6% of non-fatal occupational injuries resulted in days away from work. Medical studies indicated that nearly 25% of all mild traumatic brain injuries occur in the workplace. In 2018, almost 8,000 construction workers suffered from head injuries and 230 died from their injuries. All right, next. So those are pretty staggering statistics about injuries, specifically head injuries. So again, how does this happen? What are the common causes? Slip and falls. And then there's falling objects, impact with stationary objects, work-related motor vehicle accidents, and direct contact with overhead hazards. So I've had lots of patients slip and fall on the ice as they're delivering oil out on icy surfaces. I've had patients who work for, say, delivery services, and boxes have fallen on their heads while they're in the trucks or getting those things out. Impact with stationary objects, people just hit their head on a door or a trunk of some sort. Work-related motor vehicle accidents, pretty self-explanatory. And then direct contact with overhead hazard. Another patient who works in crawl spaces and whacked his head repeatedly on the low ceilings that he was working in. Next slide. So the impact of traumatic brain injuries in the workplace, 1 in 4 MTBIs occur at work in adults. Workplace brain injuries are associated with substantial productivity loss, economic burden, persistent symptoms, and occupational disability. Next. So the diagnosis of concussion, as I mentioned a little bit earlier, is really tricky because it's really a subjective evaluation and assessment. We don't have an X-ray test. We don't have a blood test. We don't have a any one specific test that can tell us, yes, you have a concussion or not. It's really about putting together the constellation of symptoms with the mechanism of injury and determining, what type of injury there is. It's really about the history of the physical and figuring things out. Symptoms can occur at the time of the injury or can often be delayed hours due to remodeling of the brain as well. So signs and symptoms of concussion, there are kind of 4 facets to it that we look at: the emotional pieces, sleep disruption or sleep issues, the physical piece, and the cognitive piece or the thinking piece. Okay. So the affective piece, so someone initially hits their head and a couple days later, they might have increased anxiety, depression, emotional liability, difficulty with mood swings and stuff, irritable, personality changes, and sadness. Next. The cognitive or the brain symptoms, or the thinking symptoms, I like to think. Sometimes there's confusion, amnesia, delayed physical and verbal responses, difficulty with remembering. One of the most common things I see is people tell me that they feel like they're in a fog. They feel a little bit stunned or slowed down. It doesn't always have to happen with a loss of consciousness, but there is, again, loss of consciousness at the time of injury. Some will have slurred speech, a vacant stare. A lot of times when people first tell me right after the injury, they definitely will feel like in a fog, or they're not sure what happened, that disorientation, that stunned feeling. Okay, next. So sleep gets affected. Either they're not able to fall asleep, they're not getting enough sleep, they're sleeping too much, or they're drowsy or sleepy during the daytime. So physically, people will experience headaches, and headache is the most common thing that we'll see. With that, they'll have some noise and light sensitivity, blurry vision or double vision can happen. They'll feel lightheaded. There can be nausea, vomiting, convulsions or seizures, very rare, but that can happen. Another big one that I see a lot of is tinnitus or ringing in the ears. And of course, fatigue goes along with a lot of this. Next. So assessment tools, we rely on, again, there's no specific testing for diagnosis, but we can use some tools to help us figure things out. So in the hospital or in the physician's office, urgent care, emergency room, there are a tool called the ACE, which was developed by Heads Up, which is part of the CDC. There is a neuropsychological tools called the, oh yeah, go back, yep. The next one is the ACE, keep going. You can, yeah. So this is a copy, it's difficult to see, and you can Google this and get it off the CDC. It's called the ACE concussion tool, and this is probably one of my favorite tools. I use it right at the first sign of an injury. They'll come in and we'll kind of grade this and work through it with them. And it's a great way to see objectively, at the time of the injury or at the time of this visit, what the patient's symptoms are. And it looks at the physical, emotional, sleep, cognitive things. It also gives a little bit of background history as to whether or not they've had previous concussions or not. The next one, please. The next tool I really like to use, and I use this all the time as well, is a post-concussion symptom scale. And again, it looks at the physical, the thinking, the sleep, and the emotional pieces. And the patients, as a self-rated scale, will rate themselves and see, where we are. And what I like about this is I give this to them at every visit, and they're able to monitor, and we're able to see where things are improving or not improving. Okay, next. So the role of imaging, so, a lot of people want to say, well, why don't we just MRI, CT them or whatever? But truth is that we only use these imaging techniques to rule out neurosurgical emergencies. So after that initial motor vehicle accident with head injury, we want to make sure that there's no, brain injury or bleed or anything like that, skull fractures. But it's not going to show us the physiological change in the brain. It's going to show us any functional changes, or rather, and anatomical changes. The brain So our CTs only measure up to 1 millimeter, and we're looking at, cellular level changes in the brain after this type of injury. There are certain biomedical markers that are being studied called the tau protein. These are still in, I'd say, experimental phases. There's no set use for them in the clinical setting just yet, but what happens is these proteins are given off after the injury through the cellular level, and we're able to measure those proteins to see if there is indeed a concussion or not. All right, next. So again, there's certain rules and regulations. Does everyone who bumps their head get a CT? No, there's certain guidelines and in risk stratification, and the Canadian CT head rule is one that we use a lot in emergency and urgent care medicine to make that determination. And again, we look at the Glasgow Coma Scale. We look at, is there signs of major skull fracture, vomiting, and their age as well. Okay, next. So one thing that I've really learned during concussion work is that there's different profiles for patients who undergo concussions. Some it's anxiety or mood issues, and that's a profile. Some it's cervical or neck issues. Another one is the cognitive fatigue or the mental fogginess. 4 is migraine. 5, ocular, where they're having double vision, blurry vision, difficulty with focus, and what they call convergence. Sleep issues, again, they're unable to fall asleep, unable to stay asleep, insomnia, hypersomnia, those things. And the vestibular piece is the dizziness and feeling off balance, or the tinnitus as well. There are certain modifiers which I put to the side of the slide, meaning that if there's a history of a patient who has pre-existing cervical issues or neck pain or pre-existing issues with sleep issues, those modifiers can impact any one of those concussion profiles and make them, additive effect to the symptoms that they're having. Okay, next. So here's a little bit of concussion tidbits. So headache is the most common post-concussive symptom. Post-traumatic headache disorder versus primary headache disorder versus occipital neuralgia, which is where the neck pain causes the headache pain. It's difficult to tease those 3 things apart, and that's what providers often need to do when they're determining where these headaches are related to the primary injury, and where we're going with treatment and plans for that. Again, that people with cognitive fatigue or mental fogginess, I'm not as sharp as I used to be, I can't remember things, I have to write down all the steps of this task, which I've been doing for 30 years. Those, are best suited, that cognitive fatigue. I like to get those patients right over to neuropsychiatry for those prolonged symptoms, and not waiting on it, really get that testing on board and going. The ocular symptoms, patients will complain of a near point convergence where they can't see things close, their eyes are crossing, they're having a lot of double vision and blurry vision. Most of these will resolve spontaneously within 3 months. Talked a little bit on the previous slide about that cervical pain modifier. If present, persistent symptoms of occipital neuralgia can be often the cause of headaches. So headaches, is it really due to the injury or the neck pain or a little bit of both? Again, sleep impairment can be triggered by the cognitive fatigue and also cause more anxiety and mood issues as well. Next. So our goals for recovery for someone who's had a concussion is to active rehab, get them back, get a multidisciplinary approach to their care. We want to get them back to activities quickly as tolerated, meaning, if someone obviously is still having a lot of dizziness and blurry vision, you're not going to want them driving their truck again. And you want to structure the care plan based on that concussion profile type. There is definitely not a one-size-fits-all approach to this. Next. So this is an algorithm from the American Academy of Brain Injury Association, which I thought was great, and it didn't come out super great on this reproduction that I tried to put up there, but it's a really great algorithm about trying to get patients back to work after a concussion or a mild traumatic brain injury. In the top corner, you'll see that there's a 72-hour mark, and the newest guidelines and recommendations say that, brain rest should really only be for about 72 hours max. And then we want to get the patients back and moving again, even with athletes. And the reason being is we want to kind of start exercising that brain, if you will, and try to get those neuroconnections back to working quicker. A lot of providers, even up to, most recently, think that we really need to brain rest until they're feeling better. We'll certainly brain rest the first few days, but then let's get them moving. Let's get, those nerve connections firing quickly again. And everything is as tolerated. If they're starting to, go for a walk up the stairs and they're getting a headache, that may not be the right time. It's definitely a stepwise approach to that as well. But this algorithm really looks at, less than 72 hours, more than 72 hours, can we get them back to light work, restricted work, all of these things. So when you can take a look at that as well. Next. So the timeline for recovery varies in a lot of people as well. Most symptoms will resolve in 10 to 14 days, and that's important during those first 10 to 14 days. One, get them moving quickly, like I talked about earlier, sleep hygiene, exercise, and cognitive rehab, working on some of those tips and tricks to get their brains functioning better again. A typical timeline for concussion recovery is about 3 months. Most people, almost 70–80% of people, will get better within 3 months. Symptom burden at the time of the injury can often influence recovery. So if you have people who have a lot of headaches, dizziness, their ears are ringing, their balance is off, multiple different types of symptoms can influence how long it's going to take them to get better. The other thing that I haven't quite talked about yet is timeline for concussion will also depend on whether or not they've had previous concussions. Headache and dizziness, again, is also associated with increased risk of prolonged recovery. Prolonged or protracted recovery is defined as more than 3 months. Okay, next. So again, as I mentioned earlier, the initial treatment is an evaluation. You want to make sure that there's no acute neurological emergencies. And then you want to recommend rest for the first 48 to 72 hours. And a lot of that I call brain rest or cognitive rest, limiting screen time, limiting noises, limiting activities as tolerated, limiting, the light that they're seeing in and going outside and stuff like that. You want to also treat their symptoms. If they're having a headache, give them some Tylenol, neck exercises, stretching, ice or heat to those sore muscles and stuff. I recommend cognitive and physical activity as tolerated as soon as they can do it, as soon as they're feeling better. Next. So symptom treatment, again, as I just mentioned, headache treatment, management, over-the-counter medications, biofeedback things, stretching, relaxation techniques, sleep hygiene. Fatigue management is something a lot of times, especially people who are working on a computer screen all day, fatigue management. So, having them take frequent breaks throughout the day. Vision problems, a lot of times it's the glare on the screen. So getting screen glare stuff, working on dim lights or blue lights, a lot of patients will have. Some with double vision will find relief with some prism glasses. And cognitive rehab as well. Persistent treatment for concussion, again, when these, after the 10 to 14 day mark and their symptoms are persisting, it's time to get them into some activated rehab, such as physical therapy, occupational speech and vision, vestibular balance therapy, referring off to neurology and physiatry if needed. If they're having a lot of that brain fog, memory issues, neurocognitive and neuropsychiatric testing can be considered, and occupational work conditioning. Next. Again, goals of therapy, it's not a one-size-fits-all approach. Everything, very subjective symptoms that we're working with. You want to keep patients moving and active, gradually increase their activities as tolerated, and minimize the symptoms so that you can improve their quality of life. Headache can really, or I speak of headache, but dizziness, difficulty with focus, concentration, all those things can certainly reduce quality of life and impact depression, anxiety, and issues when it comes back to returning to work. Next. So the prognosis, there's no standard guideline. Again, I go back to that 10 to 14 days. Most people get better, 85% resolve within 30 days. And there's a small percentage that will have persistent symptoms after the 90-day mark. Yeah, I'll get a better copy of that link. The literature has supported that patients with litigation or compensation issues consistently have reported persistent symptoms of disability due to mild TBI. Okay, next. So what factors will impact recovery? There's quite a few. One is if they've had concussions before, if they have pre-existing history of migraines, depression, if they've had any prior neurocognitive stuff, things like loss of consciousness, amnesia, and initial things at the time of the injury don't really impact the recovery or the length of time for recovery. All right, next. So complications of head injury, there are, you know, we've all watched, hopefully some of us watch football, and Tua comes to mind, the Miami Dolphins quarterback who's had multiple concussions. And, you know, the thing we worry about is chronic traumatic encephalopathy, which we see in a lot of professional football players. Another thing I worry about is called second impact syndrome, where the brain hasn't fully healed and you get an impact on top of the brain that hasn't fully healed yet, and you can get significant swelling and brain herniation death. It's really not something that we want to ever see. And it can be, you know, it can be triggered by just a minor injury to the head after an initial concussion. And again, the other complications we just talked about, post-concussion syndrome and that persistent post-concussion syndrome. Next. Post-concussion syndrome, as I mentioned earlier, is about you know, anywhere from after the 10 to 14 day initial injury, we expect them to start feeling better. Between that and 30 days or up to 90 days, we see that post-concussion syndrome. Anything lasting after that 3 month is termed persistent post-concussion syndrome. Okay, next. Again, here are some common symptoms of those persistent or post-concussion symptoms. And again, you'll see a lot of that thinking, emotional, physical, and sleep things, pieces come together, where a lot of them will have sleep disturbances, headaches, and dizziness, as I met earlier. One quick thing I want to mention on this slide is the impact of the psychological trauma, especially in patients who might have been assaulted at work that triggered the head injury. That they have a lot of PTSD, which can trigger and make a lot of these symptoms worse. All right, next. So again, here's the risk factors, pre-existing psychiatric history for that post-concussion syndrome, headache onset at the emergency department, initial neurological symptoms. Women tend to be more prone than men. CT abnormalities, if found, pre-existing sleep problems, and neck pain. Again, those goes to those modifiers that I talked about earlier with neck pain and headache. All right, next. So the American College of Emergency Physicians, again, came up with these risk factors that make patients more prone to having persistent symptoms. And again, much to like the previous slide, but the etiology of assaults is on there, as well as acute intoxication as well. All right, next. So there are several reasons to expect difference between workplace and non-workplace mild concussions or mild traumatic brain injuries. So as we know, if you fall skiing and hit your head, you still probably want to get up and go to work on Monday if you can, right? If you fall at work, you may not want to get up and go to work that next day. You know, again, it's the compensation axis, which is highly predictive of that delayed return to work. And that's what, you know, a lot of studies have seen. Although there, you would think that if you were getting compensated for, you know, recreational injuries as well as workplace injuries, that maybe those rates would be different. They did do a quick study, or a study in New Zealand, who has a universal entitlement system, and they said that workplace and non-workplace injuries had this same access for compensation, and workplace injuries were still associated with a higher risk of delayed return to work. So I thought that was an interesting tidbit. All right, next. So that's all I have there. A couple of the slides that I had added last night that didn't quite make it on, there were a couple of things I just kind of wanted to say with my experience of reviewing case studies and performing independent medical exams on these patients. You know, one thing I see is the concussion literacy will vary from provider to provider, whether it's a primary care provider, emergency medicine provider, neurologist, physiatrist, where some say, no, you can't go back until you don't have any symptoms. And, you know, we know research shows that the quicker they get back to work, the more successful they'll be, the better they'll feel, and their symptoms will improve. You know, again, in those safety parameters, of course, you know, so that delay in care initially is often an issue I see that probably will delay their progress as well. And kind of getting everyone on board with that concussion literacy and the new guidelines and recommendations, et cetera. Also getting patients into those neurocognitive rehabs quickly. A lot of times they have to wait for so many weeks before they can get into rehab. You know, the quicker we get these brain cells functioning again, the better off they're going to be. And that's all I got, I think. So questions? Trying to look for them. So I think I saw one quickly about the workplace concussion protocol. I'll get a copy of that to Karen so she can distribute that for everybody. Screen time, I saw quickly. I'm trying to get onto those chat box questions. Screen time is very, what I like to think of it is as tolerated. You know, as soon as, you know, you start to have some symptoms, you need to take a break, look away. And that break could be just, you know, get up, walk around the workstation, come back, closing your eyes, etc. Let's see. Stephanie, if patient comes in with significant head laceration from a head injury, should they be referred to the hospital for further imaging? Yeah, that's a good question. I think that if they've had any, you know, loss of consciousness, if there's a laceration, you know, especially if they're on blood thinners, if they're over the age of 65, or if you feel any depression in the skull, you're looking for a skull fracture. Or even a brain bleed. So that may be one where, you know, you may want to image them, possibly. I'm going to answer this next question. Is dizziness with activity common 3 months after initial injury? It absolutely can be. And what's interesting is sometimes patients will feel okay the first week or two, and then sometimes dizziness comes on, or the ringing in the ears will come on. It's like kind of that delayed thing, but it's not unusual to see dizziness and vertigo 3 months after the initial injury. The algorithm for return to work is the American Academy of Brain Injuries. Do cognitive symptoms decline over time like months? So, you know, there can be some certain decline in cognitive symptoms. I've definitely seen patients who have that brain fog initially, and then over time, they're like, oh, I can't remember the steps in this process. I have to have a cheat sheet now for something I've been doing for 39 years. So you can get a little bit of a decline. This gets tricky because I think there's a lot of overlapping pieces with this. There's an issue with depression, anxiety. There's, you know, what was their baseline? I hate to say it, but someone older, you know, now they hit their head. Now, is it baseline or is it just more apparent? And that's really where I think over, you know, if it's lasting 3 or 4, you know, over that 3-month time, I definitely recommend the neuro psych testing to really see where they're fitting in. Okay. Jessica asked, do you see any differences with concussion in kids compared to adults? I work with kids and see concussion diagnosed frequency for minor head injury. Do you think this is being overdiagnosed? Great question. Not every bump in the head is equal to a concussion, right? But you got to look and see, you know, definitely if they're having headache, if they're having dizziness, if their symptoms exaggerate with activities and stuff, you can certainly see concussion symptoms. It's really hard. I do agree. Like, you think someone just, leans back and bumps their head against a wall or a bleacher, that wouldn't cause a concussion, but, sometimes it can, or sometimes it's that shaking injury. It's that, that being jostled or not directly impacting getting a hit in the head, but that counter-coup injury can cause this too. But I do think that is a little bit overdiagnosed or maybe even a little bit exaggerated, but I don't have any proof of that.
There are a few questions on the chat. Do you want me to bring them?
Sure.
Forward? Okay. One was, again, asking for the link.
Yeah.
The other one, what are the thoughts on screen time post-concussion? Is it okay to return after 72 hours too?
Yeah, they should be able to. And everything's kind of a gradual return to activity, so to speak, a gradual, if they can start doing some computer work for 20 minutes and they start to get a headache or their eyes start to feel fatigued or whatever, that's their body telling them take a break. So maybe take a 5-10 minute break and then going back to it is what I recommend for that. But yeah, I don't think there's a limit, like after 72 hours, you 100% can do this. It's everything is as tolerated, which can be tricky as well since it's so subjective.
Thank you. So the next one was, do you have suggestions for sending work injured employees in an ambulance versus driven by family?
Yeah. So I have a couple of thoughts on that. So, if they're not stable, if they're, loss of consciousness, vomiting, seizures, I mean, if there's anything that you truly need EMS support for, absolutely send them by EMS. I would not hesitate to call an ambulance, especially if you're worried about, head injuries often come with neck injuries and neck instability or anything like that. Definitely don't hesitate. If the person's, up, awake, alert, walking, interactive, doesn't seem to be, in any severe, respiratory or neurological status, I do think a family member could certainly drive them. Mm-hmm.
This is from Jennifer. Any suggestions for monitoring frequency and duration? What about at home cognitive checks?
Yeah, so I know when I was growing up, and even it was if you had if you had a head injury, you had to watch them, wake them up every 10 minutes or whatever. We don't recommend that. Let someone sleep, let them rest. Neuro checks are kind of a good thing while they're awake. If you're like, hey, how you doing? You're okay, just checking in. You don't need to do a full step neurological exam. If you're really concerned about someone, say they had a significant prolonged loss of consciousness, I would anticipate that they would be closely monitored and maybe even be admitted for observation for those neurochecks. But at home, I don't really think you need to do them as much.
One more in the chat. How to differentiate the Waddle signs with the exam? Is it so subjective in a neuro? Is it so subjective in a neuro exam? I'm sorry, I'm not a.
Yeah. So I guess, so the big question is how, and I think this is what this person is asking, is how do you know when there's some malingering going on, right? And it's kind of when all the pieces don't fit together. Again, it's a very tricky thing because, I can't, measure someone's headache. I can't, measure someone's fatigue or whether or not they can truly, do all the steps to their task without having to make a cheat sheet or something. But it's really just kind of getting that gestalt, looking at all the different pieces. And when I do the IME for this, I'm looking at the detailed medical record history, the incident, the initial report of injury. I'm looking at where they've gone in their therapy, how many medications they've tried, and looking to make sure that all the pieces fit together. A lot of times, they really should be getting better and you just can't place it. And when you talk to them, it's, well, I had one patient, she's like, well, I'm just afraid to go back to work. I don't want to get hurt again, those kinds of things. But there isn't sometimes a neurocognitive or neuropsych testing can help pinpoint it the most, as far as if you're thinking that they're not being 100% truthful about their memory issues and stuff like that. But a lot of it's just kind of looking at everything. Okay.
Another one is, what kind of over-the-counter medications to treat headache do you recommend? Should ibuprofen be avoided?
Yeah, so good question. So personally, when I see patients with acute injury, of head injury, I do like them to maybe avoid ibuprofen in the first couple of days, because I'm still always fearful that there could be a delayed cerebral hemorrhage. So I'll usually just tell them to take Tylenol the first few days, and then they, just to kind of satisfy my own fear that there could be a brain bleed. And then I'll probably have them just, go on to taking Tylenol after that. I mean, ibuprofen, they can certainly take after that.
Perfect. I don't know whether we answered this one or not. I could have missed it. Do you see any differences with concussions in kids compared to adults? I work with children and see concussion diagnosed frequently from minor head injuries. Do you think it's being overly diagnosed?
Yeah, I do. I think I touched on this one earlier, but I do agree. I think that, you know, we're so hypersensitive about head injuries now, I think too, but not every bump in the head is a concussion. So really just kind of, I do think it might be a little bit overdiagnosed, but again, you know, a lot of sports injuries, kids are getting pushed around a lot. They're doing multiple sports, and they're definitely being injured. And a lot of kids hide it too, so we don't know. But I do think that as well, yeah.
I think that was the last questions. If anyone